Good morning, everybody, and thank you for joining us. Today is the first session of our palliative care education series for the 2020-2021 year. So thank you for joining us. I just wanted to go over a few things before we start for those in attendance. Please note that this is being recorded and that if your video is on, your image may be captured. So if you do not want your image captured, we suggest you turn your video off. And it's also a great idea to have it off just because it lowers the bandwidth needed to view the presentation. Excuse me. So if you can do that, that would be great. I want to bring attention to our new palliative care website. This is a place where you can go and register for all of our upcoming sessions. You can also view our archived sessions, and it keeps track of your registration, so you don't have to register every time. It also is a place for you to submit your evaluation. The link for each of the sessions is right on the first page, and also submit your sign-in sheet, which will automatically issue your certificate of attendance. So the website is at the bottom there, and if you haven't already checked it out, we encourage you to do so and share it with anybody that you feel might be interested in that. There's also there's a palliative care resource page available on there as well that has a lot of great links. So please check that out, and if you haven't already, submit your sign-in sheet through there, and then at the end of the session, the valuation link is there as well. If you have any questions throughout the presentation, you can forward them in the chat box. They will come to myself, and then they will be forwarded to our moderator today and asked during the question and answer period at the end of the session. And with that, I think I'm going to hand it over to Frances Gilbertas and let her take it away and introduce our panel members for today.
Good morning, everyone. Thanks, Sarah. My name is Frances Gilbertas. I'm a rural family doctor on Manitoulin Island, and presently I'm the acting chairperson of the Palliative Care Education Committee. I'm really thrilled actually to be introducing our first session and moderating our first session on our new platform. We're looking for lots of feedback, and a big thanks to Sarah and her team for setting up a platform which we think, at least our committee thinks, is way better than what we had before. So welcome to everyone. So the first rounds of this academic year are entitled Death in the Home in Rural Communities, What Does It Take? In order to reflect upon this question, our education committee and our partners in Northwestern Ontario assembled a group of panelists from different communities of various sizes across Northern Ontario. I'll introduce each panelist prior to their presentation. Each presenter was asked to address the following question: death in the home in rural communities, what does it take? From their unique perspective and from their unique context. After we've heard from all the presenters, as Sarah has said, we'll have time for questions and answers, and the chat box window down on your right-hand side of your screen is open. Before we start, I'd like to just put a bit of a frame around this workshop with a couple of ideas. And the first idea is the idea of a good death. There does exist a notion of a good death, which I will put in quotation marks, with lots of descriptors that are well documented in the palliative care literature. When considering a good death in rural communities, there's an additional and very unique descriptor, and that is that the dying person is not removed from their home community, which underlies the importance of place, community, and relationships in both living and dying. The second idea is something that was created by Health Quality Ontario, actually. So Health Quality Ontario has created quality standards for palliative care, which is really an aspirational document that tries to translate what good care looks like into a list of standards that we can all aspire to. So quality standard number 11 on the document, which is available on their website, states a person's preferred setting of care and place of death should be part of their care plan. So while there's no specific targets for place of death in communities, our regional health authorities, that would be our LHINs, are tracking the percentage of patients who die in their preferred place. And I think it's fair to say that all of us are trying to marshal the resources we have to support this option. The third idea that I'll bring forward is that Northern and rural and remote communities all have specific challenges that can impact their the ability to support a death in the home. And so that's part of what this presentation, this group panel is about. How can we sort of look at this broadly from where we sit in northern and rural and remote communities? So as we start with our panel presentation, I'd ask you as participants to consider how you might answer that question. Death in the home in your rural community, what does it take? So it's a pleasure to introduce our first speaker, who is Laurie Lee Taylor. Laurie Lee is a registered nurse who's worked as a care coordinator for the Northeast LHIN for almost a decade. For the past 4 years, Laurie Lee's role has been the palliative care coordinator with the Northeast LHIN. Her job is as a palliative care coordinator for the Northeast LHIN. She brings 30 years of nursing knowledge in a number of roles, including experience from pediatrics to geriatrics in many settings: community nursing, operating room and recovery, intensive care, long-term care, discharge planning at the West Nipissing General Hospital and the West Nipissing Family Health Team. So welcome, Lorelei, and over to you.
Hey, Francis. I'm pleased to be here with you this morning. Thank you for asking me to share some of my palliative care knowledge that I've experienced in the community. So again, my name is Laurie Lee Taylor, and in addition to my role as a palliative care coordinator with the Northeast LHIN, I'm also a spouse, a mother, a grandmother, and a longtime registered nurse in the community of West Nipissing. I wasn't born or raised in this rural area, so when I first arrived, and unaware that I had just moved into a mostly French community. My husband just sort of left that small little detail out. So in this small village, we were the only English-speaking family. So needless to say, that did pose its challenges with all of us. But we overcame the barriers and we still reside here today. So just to give you a little bit of background about West Nipissing, it is a vast area. It encompasses approximately 770 square miles. Not certain on the equivalency of that in kilometers, but it does pose significant challenges with cell phones, internet coverage, and regular daily commutes. The population here is mostly bilingual, with about a 70% being fluent in both English and French. There is also 2 Indigenous communities in West Nipissing. One is located just on the outskirts of Sturgeon Falls towards North Bay, and the other is located at the southernmost tip, which is approximately an hour's drive from Sturgeon Falls. So as you can see, it is a very vast area that does pose a little bit of commuting problems. As a palliative care coordinator, we work in partnership with patients, family members, and other health professionals. We focus on supporting the patient and his or her family throughout their journey. I believe that a palliative approach to patient care should be implemented and benefited from earlier rather than later. Palliative care cannot, in my opinion, be implemented too soon. There seems to be a little bit of a misconception about what palliative care actually means. Some patients and families are often taken back when they hear the term palliative care. And we often get feedback saying, I'm not palliative, or I wasn't aware my loved ones are palliative, or I'm not planning on dying. So therefore, when I first meet a patient and their family, I ask them what they have been told about their diagnosis and prognosis. I believe it's very important that the patient has a discussion with their physician about a palliative approach to their illness. So let me go back here a little while now. My first experience with palliative care at home was many years ago. The patient had a life-limiting chronic illness. The patient happened to be a child, and the parents chose their home as the most preferred location to treat their child for their own personal family reasons. We were providing daily nursing care to optimize the child's quality of life and the family's quality of life. The care coordinator had already been in the home. She had completed her initial assessment. She had implemented do not resuscitate that was tucked away in a dresser drawer, as that was the family's choice. It was not discussed with family by nursing staff but everyone was aware of this paper's location and the probability that one day one of us would need to know its location. An expected death in the home form was also placed in the nursing chart. The care coordinator had previously discussed with the physician and filled out with the family, so we were all. The primary physician was a pediatrician who also worked closely with the family doctor and a nurse practitioner. So after hours or on weekends, we always had availability to a physician or a nurse practitioner, which was absolutely necessary for this family, or the child would have likely been in hospital and the family would have yet to be separated again. They always ensured there was a medical professional on call for us. There was always someone at the other end of the phone. The care coordinator completed home visits regularly with the family, and she would implement nursing visits on a when needed basis, depending on the treatments required, which may have been once a day or 3 times daily, depending on the patient's overall well-being. The care coordinator would oversee the patient's status to determine her level of care, discuss the family wishes and ongoing changes with goals of care, and have discussions and receive and implement orders from physicians. At times, it was rather hectic in the home, with other professionals involved that the care coordinator had referred for the family, like physiotherapy and occupational therapy, respiratory therapists, dietitians, SWs, respite volunteers, and even their priest made home visits. No cell phones or internet was in this outlying area, which made it even more challenging. The challenges for this family were real, and their other children in the home were forefront. Our nursing skills also involved compassion and always a shoulder. The other children lots of times were in the room with the patient, and we would have to incorporate activities with all of the children in the bedroom so they were able to assist their sister while we delivered our care to their sibling. As the days and the months went by, though, it became increasingly clear and that the continued treatments were futile. And as per the family's choice, only comfort care was then administered. The physician ordered a symptom relief kit early on. So when her PPS dropped below 40%, the kit was dispensed verbally by the care coordinator and was placed in the home. The family were aware that they may be required to administer medications in our absence, as nurses would not be there 24 hours a day. And if they needed us, we were on call, and at times it could have taken an hour, 2 hours for us to get into the home. The family was agreeable to this. We all knew that day would come when we received that phone call, and sure enough, it did. The family were aware that the nursing staff may not be present with them when they witnessed their child's last breath. During the long drive to the home, I had lots of time to reflect on how I was going to react, but nothing could have prepared me. I arrived at the home. I pronounced their daughter. I supported the family in their time of grief and contacted the funeral home as per the directions on the expected death in the home and followed the family's wishes. I was thankful at that time that the care coordinator had laid out clear details of what to do and who to call, because you see, I was not a trained palliative nurse, but I was a skilled and compassionate RN. I truly believe that a palliative approach to patient care should be implemented and benefited from earlier rather than later. I can't stress this enough. I don't believe it can be implemented too soon. So in hindsight, let's move forward to today. It's 2020 now. So where am I am the palliative care coordinator in the home, and these are the obstacles that I am challenged with. Procrastination is certainly the thief of time, as I've always said, and it's never too early to start advanced care planning discussions. Community visiting nurses are not always readily available, and the patient and or family may have to wait upwards of 3 or more hours for a visit, depending on their location, if it's an evening, if it's a weekend. Visiting nurses are not just RNs anymore, so there are different skill levels of nursing abilities. We also can't count on a nurse to initiate or restart an IV or titrate a medication in the home or initiate CAD pump orders. We only have a handful of trained palliative nurses in the community, and they range in different levels of nursing skills. Now we have to also take into consideration we're dealing with a pandemic, which also reduces to us. Scenarios have strong family supports. Early discussions of advanced care planning and implementation of end-of-life documents like a do not resuscitate, an expected death in the home, and a symptom relief kit for patient symptoms. Poor scenarios with some hurdles. Delayed initiation of a palliative approach. For instance, a patient with diagnosed stage 3 cancer undergoing curative intent treatment progresses and all of a sudden is told there's nothing more that they can do. Here's the most recent scenario. An oncology patient undergoing treatment, currently at a radiation oncology appointment with family. I'm notified by the hospital nursing staff that the patient is being referred to me. Reportedly, he's going to be en route home with his family driving him as per their wishes, and his PPS is 30% and declining quickly. The hospital nurse advises me she's not certain he'll even make the trip. I advise the hospital nurse to ensure that the do not resuscitate confirmation form is completed prior to his departure and given to the family with the instructions. I had to explain that that's the form with the red numbers in the top right-hand corner. A photocopy will not do. So now I'm scrambling, having end-of-life conversations inappropriately with the patient and the family while they are traveling and they are trying to absorb all of this new information. Hospital had offered to admit him, but the patient wanted to go home to die. This was his life, his choice, his journey. I had 2 hours to speak to this family and patient about advanced care planning, end-of-life wishes, confer with the family doctor, complete the expected death in the home, obtain in fax symptom relief kit orders, ensure that another family member was going to be able to pick up the medications at the pharmacy at the other end, implement equipment and expedite delivery and setup in the home, referral to OT, the occupational therapist, to ensure the equipment was all in place, and nursing. And I had to assure that the visiting nurse was there to greet the family upon their arrival. Then I had to call and beg community support services for a PSW to ensure they were able to support that family. The family and the patient did arrive home. He was put into a wheelchair and taken into his apartment. The patient died 3 hours after his arrival home. It could have been so different if an early palliative approach to care had been initiated. Family and patient did not have time to react. They thought there was a curative intent. What do we need for a palliative approach? What I'm looking for as a care coordinator, it would be beneficial for the physician to discuss with the patient his goals of care and a palliative approach to treatment, and state that I'm going to refer you to a palliative care coordinator. If you're questioning if a patient undergoing curative treatment would benefit from a palliative approach, then just go with it. We assess the patient's services in the home that they may require on a PPS scale. A symptom relief kit is usually implemented when the patient's PPS is 40%, and it's dispensed from either the Sudbury or North Bay pharmacy, and that's depending on the patient's location. Most of my patients tell me their preference is to die at home, and I inevitably want to make their wishes come true. Home is their peaceful, familiar environment. It's comfortable for them. So meeting with the patient and family in their home is of utmost importance, especially during these times of COVID. It tells me of their surroundings and available family or friends that are their support systems. One of my favorite quotes is, "We tend to plan so much for a birth, but so very little thought into planning for end of life." I have to say, though, that the old saying that it takes a village to raise a child, I have learned from the Indigenous people in this area that it takes a village to plan for the end of their life. How they come together and support each other is just phenomenal. With the palliative approach to care, a positive home death can be achieved. We need to be team players, because even during the best play, the patient or the family can change their minds. All the community nurses have my cell phone number. I've told them if there are any issues on evenings or weekends that they can't resolve, that they have my number and to call me. I'm always accessible to them. I'm just the conductor. I can assist and give patients and families their options, but the final decision is theirs. If they want to hop on or off the train, it's their journey. Thank you. That's it.
Thank you so much, Laurie Lee. So our next presenter is Valérie Abel. Valérie is the home and community care nurse manager for the Indigenous community of Constance Lake First Nation. Valérie is a native of Hearst, Ontario, a 95% French-speaking small town of around 5,000 people. She became a mother at a very young age and started with her PSW certificate and then went on to obtain a nursing degree. During her schooling, she had to work to support her family, giving her the chance to also live very diverse experiences. She worked at the hospital in Hearst as a PSW and as a nurse, and at a long-term care facility as a casual worker. In March 2017, she began her current position in Constance Lake First Nation, which is a population of about 1,000 people, located on the shores of Constance Lake. Sorry, I lost my spot. In this role, she's been given the opportunity to see what the needs of an Indigenous community are, and to assist in setting goals for the community to help them achieve their goals. And she states, "This would not be possible for me to make happen without the help of my HCCP," that's, I think, Home and Community Care something team. Welcome, Valérie, and over to you.
Okay, so I'll go as you guys listed the question, and then I'll just brief you with a little story. So what does it take when I'm thinking about it, that in the home of a rural northern community? Well, how I do it, I organize family circle with social workers, the families, and then we talk about family wishes, client wishes. That's where I organize resource with the OTs, the PTs, which is for us, it's if they need equipment, meaning the wheelchair, the bat support, all the equipment needing in the houses. And then I'll check with the family physician, because since, like you said in my bio, Constance Lake is not in Hearst, so all our services is coming from Hearst. We have to go and look for our services out of the reserve for the clients to get them. So this is hard for us to get all the services needed for our clients. So I gotta make referrals every time for the clients that are palliative and wants to die at home, or even if they want to die at the hospital. So that's why I gotta organize family circle as soon as I get a referral that somebody is a palliative care. So for me, it's as soon as I get a referral is we organize first a family circle. We get the family wishes. We go to our resource. I contact the family physician. When I'm at the family physician loop, this is another it goes in the loops. Half of our community do not have family physician because we are in the lack of family physician. So I have to go and bring them to the emerge, and we consult the emerge doctor. So that's where I'll talk to you later about that. I spoke with the family members about, is there a POA? What do we do about the POA if we're there? Is there anybody willing to be the POA? And in the Indigenous community, often nobody wants to be the POA. Nobody wants to take that responsibility. So often that client dies without a POA, and then it's another issue at the end. If the client becomes from the hospital and wants to die at home, I have like a binder, and then it's like arrow A, arrow B, arrow C. So if he comes from the hospital and wants to die at home, we go from, I'm requesting the nurse in charge for a lot of things so I can actually accommodate the client at home and do the rest of my job at home. So in order for me to be able to assist a client to die at home, I'd say I need a medication list in order to be able to serve him his medication. If the client is still capable of living for a couple weeks and up to months, if he needs blood work, we'll take his blood work recs. Any follow-ups care with doctors, specialists, oncology, cancer treatments, I'll request those. We have two things with Ingenitus Care people that we request as soon as we know they are palliative, is a requisition from the doctor that is a prescription. It's called Incontinence Care as Best Practice, and the other one is Wound Care as Best Practice. The reason that we request this is either if they are, or if they have a wound, and if they have a catheter insertion at the end, we are able to order any supplies and they will be covered by NIHB Act. So as soon as they are being discharged, or they, even if they're at home and then they become palliative and they want to stay at home, those are two things that I'm going to get a physician to order, so they do not need to pay for their supplies, and then I can provide those service and I get the pharmacy to just send me the stuff. And this is not something for them to worry with the wound care as best practice and incontinence care. Even someone who just doesn't have a catheter but can't get out of the bed and we just need to start putting the Depends, he can get an incontinence care as best practice, and then the Depends will be paid through NIHB. We'll have the Depends at home provided by the pharmacy. I also start with an initial pain assessment and the symptom scale, the PPS, the Edmonton scale, an infection control. I'll go over a DNR form either with the family or depending if he comes from the hospital. I'll talk with the family and the client with the IDIT form that it's expected that at home, depending again if his wishes are to die at home or go the last moment of the client. And then I'll get either the nurse practitioner or the physician to co-sign or sign the last forms. For us, I know, Laurie, you were saying about the palliative support kit. Because we are too far north, we can't get those because we can't leave them in the house. It's not safe because we got bad issues that they were not being used by the clients. So what we do now is we did change that kit for the Naxalon kit and the nurse, which in my community, I'm alone. So that is another issue for me. I have to serve my clients alone. So it's the Naxalon kit that replace our palliative support kit, and I have all the meds, and when I go, at least my backup is an Naxalon if something happens. So how I do it, most likely when I get the client or I know the news, is I sit down with the family and the client. I have to explain step by step according to what they know, what's coming, and what's gonna come afterwards. If their wishes is to stay at home, I'll bring forward the edit form and I'll present what it is. I'll let them know often what is expected in the community, what is offered, what our service are as the home and community care program. I'll let them know that I can be on call, but again, I'm alone as a nurse and I have my staff as a team of PSW. I work Monday to Friday, 8:30 to 4:30. I'm really flexible with my on-call. So if there's any change in the client's symptom or she decrease, the reserve is about 45 minutes away from Hearst, so I can travel back and go assess the client. So usually when I see the client do decrease or it's a palliative care, I will start giving my cell phone to the family so they can reach me. But I let them know that it's not just to call me at any time, it's really for important concern. I keep my PSW on call during those time for those clients that are on reserve. So if they do call me and tell me, well, I think she's on distress, sometime I'll just page a PSW, she'll go, and if she finds there's really a change, then that's where I'll come in because I have to travel. Another reason how I do it is because I really have a passion for the palliative care. I love the family support. I find that's really the key, and I wouldn't do it again without the PSW and volunteers. And the training is accurate. Even if I find if you got training in the past, you can still take more training and it will help you. How do you do it with with my organization? We created lately policies. I even developed a respite / palliative room. We have like an elders complex, which is just a single apartment living, and we decided to keep an apartment just for a room that if ever, because of the pandemic of the COVID, it made us think that we had an elder dying at the hospital and nobody could go and assist her to die. So we decided to develop that room so that if ever the pandemic continues or we have another pandemic, at least our community members can have access to that room to die, and then their family could go visit them on a daily basis because at the hospital they couldn't go. And we know that Indigenous people have certain beliefs like smudging, stuff like that, and at the hospital it was not permitted during the COVID. So this is what that pushed us to develop that room. So what we did is we did develop to that room so the community can go and use this room, and it will be on the reserve. We're allowing everybody to go, but again, following the COVID rule, so one people at a time. We'll be giving the care over there. It's not a hospital setting, it's a house setting. So this is my new, basically, my new project this year for the palliative care setting. So in that's what I have my binder. I have all my information stored in that room. I have all my supplies. I have a little storage room that I keep some supplies in stock. So let's say I still have my catheters stuck there. I have my IVs. I have, if anybody arrives on the reserve and tells me that I'm palliative today and I might have 2 weeks to live, I have 3 months, my supplies are stored there. What are our PIF, BAF, and challenge? And how do we work around them? Well, every client is a different case, and we deal with case different how they are. So how I can say that is also every house is different. So I can't bring my lift to every house. I need to use different equipment depending on where I go. Sometimes we lack of staff, so we got to make more hours. It can be burning on our caregivers, and then our caregivers are at risk. We have to promote self-care. I have to make sure that I get my social worker part of my team, even if it's for the family, it's also for my staff. So sometimes our family will refuse to talk, but I also encourage my staff to use it for their self-care and to talk about what they see, because our social worker is part of our team. In northern communities, sometimes we don't get the equipment in time. So this is another PIF-BAF. Like my last case, we had ordered the CAD pump, which is the lock pump for the control medication. And our client was supposed to do maybe a month, but she did a week. So the pump didn't arrive in time. So I had to do the meds by IM daily. So this for us is a big PIF-BAF because they come from Toronto and we're 12 hours from Toronto. So by the time that we order the supplies, we get the equipment, that I can install the equipment, and we start the treatment, often our clients don't have the time to get what they need. So I have to do it manually, like if we're 10 years backward. So for us, referrals, resource are very important. We do deal with VON, CCC, or like I said, otherwise I would have to make it all the old way. IV, I still have to make it by gravity, or VON has to make it by gravity if I don't receive my equipment. What is our biggest frustration? Well, being in the north exactly and not having all the services in our hand in the proper time range, and not having access to the proper staff at times because I'm alone as a nurse. I can't be everywhere 24 hours, 7 days. And palliative care, that's what it needs when it's the last days. It's frustrating. So that's a big frustration. How do we measure the success? I could say that when we see the client is comfortable without any pain and the family is reinsured, that's how you measure the success, because you know your client as well and your family is not worrying. How do we keep doing this work? For me, it's just because I love palliative care. I know that I'm doing well to my client, and it's something that I love. I do it with passion. My top tips for a new provider, what I would say is something that you will either click or won't click with it. Palliative care, for me, it's something that either in a house, in a hospital, in a settings, you will assist the client to go to his journey. Connection with that person. And for my personal experience that's where like I'll go with my story. With my other clients, I have always noticed that when you click with your clients and you assist them to their journey and you do the palliative care, you learn to talk to them, you learn to do their cares as much as if you're a nurse, you're whoever in the house, a volunteer, a family, you bathe them, you wash them, you do everything, so you connect. But the most important is you need to talk to them, and you still need to let them know what's going on at all time. And often of that time, they might let themselves go with you instead of their family, just because they do not want to let their family suffer. And that's where they'll let themselves go. So you got to be ready for that. You can't be afraid of that. And that's it. Thank you.
Merci, Valérie. I think you are our farthest north person today and probably the coldest. up there. So our next presenter is Alexis Peplinski. Alexis is a palliative care nurse practitioner. She was born and raised in Kenora, Ontario, and graduated with a Bachelor of Science in Nursing from the University of Toronto in 2005, and then graduated again, from Lakehead in 2013 with a master's degree in public health with a nursing specialization, as well as her primary care nurse practitioner certificate. Over the years, she's worked in various fields, including pediatrics, public health, corrections, primary care, critical care, and emergency medicine. For the past 3 years, she's worked in the community as the sole hospice palliative care nurse practitioner for the District of Kenora, providing palliative care, end-of-life care, and pain and symptom management for patients in the community. In her non-work hours are filled with time spent outside and going on adventures with her 2 children and her pet dog. So welcome to you, Alexis.
Thank you. Good morning, everybody. And I'd like to just start by thanking Laurie Lee and Valerie for what you've highlighted in terms of what it's like working in small and rural communities, because a lot of those challenges are the same challenges that I am faced with in Kenora specifically. So my district of Kenora is a huge catchment area, including the community of Red Lake and everything in between Kenora and Red Lake. Which is a challenge because Red Lake is about a 3-hour one-way drive for me from Kenora on Not Great Highway. Primarily, my practice is based out of Kenora just because of the volume that we see in Kenora and the large catchment area that I have immediately within Kenora. So Kenora is the last town in Ontario heading west before Manitoba. For those of you that are further east, we have a population of about 16,000 people, which doubles to triples in the summer months. It's definitely cottage country equivalent for our Manitoba residents. And within about an hour, 100-kilometer radius of Kenora, I have 11 Indigenous communities that I also serve. So it's a large volume for a sole provider. So what does it take, I feel, to work in this field? Palliative care NP is definitely, like Valerie speaks to, is the passion for it. Like anything in our healthcare system and in medicine, you kind of find your niche, and that's something you believe in and you love to support. And for me, that has definitely been palliative care. My position was vacant for 5 years from the time they received the funding until it was filled by myself. And I've been able to build a program in Kenora and really fill a need that wasn't here previously. Because like I'm sure for so many of you, the physicians in your communities wear many hats, from primary care to emergency medicine to obstetrics to surgical assist and whatnot. So adding another, a fairly specialized area for a lot of them is just outside of their capacity to be able to do that because of the hats that they wear. So for me, it was identifying that there's this need in my community and I have this opportunity to fill it, which I feel I've done fairly successfully over the years. Working in palliative care, though, there has to be an acceptance of death and dying and what that looks like. And Francis, when you speak to what a good death looks like, coming primarily from emergency medicine and critical care, you see death in the sense of trauma, and you see unexpected death when people present to the emergency departments. And it can be quite traumatic for families. It can be quite traumatic for staff. And I find working in palliative care is it gives you that opportunity to, create that good death, to uphold people's wishes, to empower them at the end of their life to have a choice as to where they are and what that experience looks like for family as well as for patients. The other thing I love about working in a small community, though, is also how family-centered palliative care is. I started my career originally in pediatrics, where it's very family-centered. So when I first came into this role, that was the draw for me. Coming to it was it's not just a patient focus. It's a family focus. And when you have limited nursing services, when you have limited supports in a community, you need to build that rapport with families. You need to develop that relationship and have that family approach. So I think that's really important for someone that's in this role. The other thing that I find is helpful in terms of, what does it take, is how do you normalize death and dying? We live in a society that it can be very taboo to talk about, especially, I know, Valerie, you can relate to this as well with your Indigenous community. You don't talk about it, right? And I think about the conversations I have within my own family and the conversations I have with my children, and my children are they're young, they're 6 and 8. They fully understand what mom does, and asks, oh, did that person pass away, right? And it's a normalization of the death and dying experience when you work in palliative care that I think provides comfort and a lot of understanding to patients and families. So I often get asked in a small community, especially, like, how do you actually do it? And I think for me, it's been my experiences over time, seeing those not so good deaths, seeing those good deaths, and just being able to know that you're making a difference in a community really makes a difference for me, and something I'm really passionate about. I also believe strongly that you should have a life lived with substance. And quality of life is really important. And I often tell people when I get involved is my approach is going to be very different. If you don't want to talk about cure, we don't have to talk about cure. Like, that's not my primary driver. Let's talk about what you actually want. And I find with a lot of patients, they haven't had those conversations before, or they didn't feel that they were in a safe space that they could ask about that, or even have the option of declining treatments. So just being able to open that conversation. In terms of how I organize myself, in terms of my actual clinical practice, I really organize myself based on where people are on their trajectory towards death. What is their symptom burden like? What can we do about that? How can we change it? How can we improve things for them? How can we improve their quality of life? What are their goals of care? What are they trying to achieve? I had one particular patient last summer, and her goal was to attend her granddaughter's wedding out of province, included a flight. She was on home O2. And so how do you navigate that? How do you support her? How do you manage her symptoms as best as you can to make that a positive experience? So it's not about, we should do this, this, and this. It's what does she want to do? What does she find manageable? And trying to make it happen. So I try to organize myself that way around that symptom burden, essentially. And COVID has brought a lot of challenges to that. Working, because I am employed by the LIN and Home and Community Care, is the shift to virtual visits. And how do you provide virtual care to someone who's at the end of their life? It's really, really challenging and really difficult to manage. And trying to find that balance of what can I manage virtually? What can I manage on the telephone? And really knowing when is your time that you have to see that person face to face. So figuring that all out, I'm not very good at, I will be honest. But luckily, when you're a sole provider, you can kind of muddle your way through it. Some of the pitfalls and challenges that I have definitely is working in a small community. And when you talk about, Valerie, the self-care piece that comes with it, working in a small community brings the challenges of you're going to be looking after family friends, you're going to be looking after, classmates. Even the handing out of telephone numbers and whatnot. It's difficult when people call your mother on a Saturday night looking for your phone number as a sole provider in a small community, and people know you. And, there's no off time, I find, because you're at, a kid's activity at the hockey rink on the weekend and someone is asking you, this didn't work last week with mom, or, my aunt's having trouble with that. And as much as you're trying to maintain that confidentiality because of the family approach to it, because of that small community dynamic, it's really difficult. And even just sort of that check-ins for myself in terms of my own mental health and my own self-care is what's that balance between the off time and the on time, because there really isn't a lot of off time. Some of the other kind of pitfalls and challenges is being a sole provider and not kind of being able to be everything to everyone always. And how do you figuring out how to manage that and setting some appropriate boundaries around that, I think is really important in some rural communities, because there's going to be times that you aren't available, and that you have to figure that out. Some of my biggest frustrations, definitely, as the two previous speakers have spoke to, is the limited resources. So we do not have 24-hour nursing. We have one community contracted nursing agency in our community who has struggled with staffing. As many of you, I'm sure, are aware, there's a large discrepancy in income between community nursing and, say, hospital nursing. And it's definitely reflected in the difficulty that they have in recruiting qualified staff to the positions. So we have that is a huge frustration and huge challenge for me in this community. And then, like I said, even my own limitations of just not being able to be everything to everyone always is something I struggle with. I'm a person who has a difficult time saying no. And because I feel so passionate about giving people a good death and supporting families and patients in their home, it's difficult for me to say no. So how I measure my success is definitely the personal feedback I receive in my community. I have a very supportive medical community that supports my role and advocates for my role in the community, even with the shift to Ontario Health Teams. There's been a lot of advocacy to keep my role and actually add to the role in this community of Kenora, just because of the volume that we do see here. And I say my repeat families. So those families that come back to you with the next family member who's entering the palliative stage saying, we'd really love you to be involved in their care because the past experience was positive for them. So I use that as my measure of success. In terms of why I keep doing this work, having been born and raised in Kenora, there's definitely a need here. And knowing that I'm filling that need, we're also a community where there are more nurse practitioner positions than there are nurse practitioners. So if anyone knows anyone, so there's not a lot of movement of nurse practitioners within the community. And I struggle with the idea that the role wouldn't be filled potentially. And because of the vacancy time that it had prior to me coming into it, palliative care is specialized. As the previous speaker said, it's something, you're dedicated to it, you're passionate about it. And I worry leaving a role that may not be filled with the same enthusiasm. And I see the difference it makes. I see how we remove strain from our hospital system and we support people at home. And it's exactly why I keep doing the work I do. And also just seeing the positive experience that people have at home. There's no better feeling for me when you have a family who, no, we're going to hospital or we're going to hospice. This is what we would like to do. And then it ends up sort of plan B being a home death, and it ends up being a good home death. And the family is so relieved and feels so supported in being able to do that when they think they didn't, I think is such a fabulous, reward for me. Some top tips for a new provider. And I really thought about this because I came into this role having never worked oncology. I've worked a lot of spots, but never oncology, never home care, never community care. And I've been involved in some training of new people in rural communities. And so I thought about, what does it actually take? I think my tips for a new provider or someone entering palliative care is the ability to be flexible. Having a home death is not like being in the hospital. I compare it to camp nursing, actually. This is what you've got to work with and you need to make it work. It's like dispensing medications out of a fishing lure box. And it's sort of, what do you have on hand? How do you make it work? Like, is this the most sterile technique? No, but this needs to get done. And this is what I have to work with. And it's sort of, as Valerie talks about, even just being able to access equipment in a community, we sometimes have those challenges as well. So just being flexible in what you're doing. The other part is being available. Families are often in crisis. And like Laurie Lee talked about, is having those early conversations and being comfortable talking about death and dying and normalizing the experience and being available to families, because when you present those conversations, they're not always ready, but they may come back to you in an unexpected way when they are ready to talk about it. And I think it's really important to be available to meet their needs when they're ready. The other part is just being honest, normalizing the death experience. We will all go through this journey at some point in time, and regardless of what your health conditions may be. I think just being honest about that, about what to expect, what things may look like. I've received so much feedback from families to say, oh my God, I'm so glad you told me what those last few hours, like I was shocked when you told me, but then I wasn't when it happened. And I knew that that was normal. So just being honest about that. The other part is have those hard conversations early on. It kind of my challenges and the things that frustrate me are those late referrals that, oh my God, this person, is coming home today and they're end of life and their PPS is 20 and nothing's in place. And it's just like, this person's been a stage 4 cancer and has been on a palliative trajectory for months now. Let's start that process early. And I know so many people are fearful of palliative care and associate palliative care with I'm dying. And I try to change the language around that from, it's not about you're dying and that there's no options. It's about palliative care is about good care and improving your quality of life, no matter what amount of time you have. So having those hard conversations early and just approaching it in a positive manner. The other part is using your team, especially in small communities, because you need to support each other. You need to be there to lean on one another, and you need to use your team. And your team is also the family. I think that's the most important part. You need to build that rapport with the family, because when you have limited services in a small rural community, it's the families that are going to be doing the hard work at the end. I teach my families how to administer medications. I prepare families for what it's going to be like when they pass and there's no other supports there but the family. And they really are your biggest allies in supporting a good death and a home death in a rural community. And they're also the ones that you're going to see at the hockey rink the week after. So I think it's really important to have that rapport and support those families through that journey. So that's all I have. Thank you.
Thank you so much, Stephanie. Alexis. So our next presenter is Simone Mickelham. Simone is a rural generalist family physician and associate professor at the Northern Ontario School of Medicine, who practices here on Mickelham Island in the community of Little Current. She graduated from the University of Western Ontario's Medical School and Family Medicine residency program. And I think she holds a specialty certificate in emergency medicine as well. She was born in Sudbury, raised on the North Shore. And Simone has worked in Northern Ontario for her entire professional career as a comprehensive family physician. And that would include, of course, home and hospital-based palliative care. She has been based in Little Current for the past 13 years or so. And I would like to announce this, was recently appointed as our Chief of Staff at the Manitoulin Health Center on September 1st. So congratulations and into your early tenure. Her interests include hiking, traveling, and the piano. So Simone, welcome and over to you.
Thank you very much, Francis. I'd like to thank all of the previous presenters. I think it's great that there's such a variety of presenters and showing us their points of view about what a good death at home is. As I was thinking about this talk, I thought I would start where palliative care was when I first graduated 25 years ago and moved to Espanola. I was very fortunate because my preceptor in university was a physician who did a lot of palliative care. So adequate training, as was available at the time, I think was a very important part of my feeling comfortable providing deaf support at home, because I did a lot of that as a resident. When I first started, death at home, a good death at home would involve me and a home care nurse and family. I had to write prescriptions for meds and have them delivered at the home. There was no symptom relief kit. There were home DNR forms still already then to prevent the paramedics from having to begin CPR on a patient. There were no cell phones, and so even to get a hold of me could be a challenge. And so a good death, I think, as now, is one that was planned, that was organized, that had family on board, that had the patient on board, that had adequate home care resources, which have always been a challenge. That has not changed in 25 years. And that was peaceful. And where the patient was able to die at their preferred location, which is often still home. I mean, that's where people wish to die, many. And to me, those were good deaths. And I remember many of them. And I felt an intense satisfaction with helping people die well at home. My family remembers me being called out Christmas Eve to do a pronouncement, or being called in middle of the night to go assist with a problem at very odd times. And so those deaths at home were great. Deaths that did not go well at home are exactly what the people and before me have commented on. They're frantic deaths. You're trying to get everything in place at the very last minute, and everybody is upset and everybody is anxious, and often the things that the patient needs are not present in the home. And like my previous presenters, these are not unexpected deaths. We see these deaths coming, and for a number of reasons, any number of reasons, the proper wrap around that patient to prepare them for a death at home has not occurred. And that was, I think, even more so 25 years ago, but still occurs now. There were limited options to patients 25 years ago. For example, medical assistance in dying at home as the preferred approach of the patient was not available, which was heartbreaking at times. The care was very, I found, provider specific and provider centric. So maybe I was able to provide home care, but perhaps my colleague was not. And depending on when end of care happened, if I happened to be on holidays or out of the country, that patient had to be transferred to hospital because there was no other person who I could sign that care of the patient over to allow for ongoing care of that death in the home. Someone had to sign the death certificate. Someone had to come and do the pronouncement, and that was a physician at the time. Could not be done by home care staff. And so it was, I found, very provider intense from a family doctor perspective. And I could handle one such patient at a time. But if I had 2 or 3 of them on the go, that it was a very challenging situation. Compare that to moving to the island and more recent times. I think there's already been a significant number of improvements that have occurred that have improved the death experience in the home and the ability to provide a good death at home. Definitely the introduction on our island of a palliative care NP, and I see that Sue Robinson is on, and I found having a palliative care NP invaluable in a support to my patients, to the home care nurses, and to myself as a content expert. As a family doctor, we're expected to wear multiple hats. And while I feel fairly comfortable and I've taken extra training in palliative care, the skill set of a trained palliative care NP, I think, is an invaluable resources to the communities that they serve, both the patients and us, in terms of providing that care. The availability of a symptom relief kit to be delivered and kept in the home in a safe way is invaluable to the patient, again, to prevent that last minute running around. How do I access this? How do I access that? Having all of the appropriate paperwork and conversations with the patients done ahead of time has been very valuable. And again, that's where the home care nurses, having those conversations with the patients, developing those relationships with the patients has been great. So one of the big advantages I see on Manitoulin Island from a family doctor's perspective is I'm no longer the only game in town for the patient's palliative care. And that's very good for the patient because I can't always be available. And it's very good for me as a provider because it takes some pressure off in terms of I'm more than, it's easier to provide that care in the home, knowing that I can sign that care over to a colleague, that there is a palliative care NP that can provide care, and that there is home care, skilled home care nurses to assist that patient. The other big advantage, which no one's spoken to before, is the new program for caregiver benefits to allow working family members time off of work to come and be at home with their loved ones. That wasn't available when I first started working, and has in many cases made the difference between whether or not someone can die at home or not. Because so many children work full time and they may be away from the home setting, the ability to be able to take time off of work, protected time off of work, and be at home with their loved ones to receive the proper training and care and support to support their loved ones in the home, I think has been a major advancement in providing palliative care in the home. So shout out to whoever made that happen. Ongoing issues that we have, it's lack of adequate funding for home care. Our poor home care nurses cannot work 24/7, and yet, palliative care is not a 9-to-5 job. Patients have palliative care needs that come up at night and on weekends, and there's variable access to home care nurses during those times, variable access to our palliative care NPs and to us. And that continues to be a real challenge I find on Manitoulin Island. I see that both Dr. Jeffrey and Dr. Stadnik are also on the call, and they have even more experience than I about providing palliative care on the island. I find that we still have issues as well in terms of supplies. So like Valerie, our CAT pumps supplies are not local. They have to be brought in from afar. In our case, Sudbury, so it's not 12 hours, it's 2. But still, it's very challenging to get those things at night and on a weekend. So those things are an ongoing challenge. So in terms of providing for good care, good death in the home, I identified quite a few things that I think already are happening but could be done better. I think that we need adequate training of ourselves, both as providers, and that starts at school, and as dedicated teachers to make sure that our students get adequate training in palliative care, and that we show them how fulfilling providing good palliative care in the home can be. So I think education is huge, and the providing of things like the LEAP course and to provide us with comfort in providing palliative care did not exist when I started practicing. So again, a major improvement, and I think ongoing courses like that would be very valuable. I think there has to be adequate funding for home care so that we can provide that seamless coverage, that seamless 24/7 coverage. Even recently, we've had issues with patients wanting to die at home and not being able to access home care, like I, as a provider, not being able to access the home care nurse to let them know about changes in the patient's status, and the patients themselves not being able to access the home care nurses. And that is not from a lack of desire from the nursing staff. It's just that there isn't enough nursing staff to provide that wraparound care even today in some of our rural and remote communities. From a patient's perspective, again, like others, I've struggled sometimes with patients who don't who see not they don't want to have the conversations around palliative care. You know, they're actively engaged with chemotherapy or radiation, even though they have stage 4 cancer. And that's really what they want to focus on. They want to focus on living. And they see any conversations around palliative care as conversations around giving up and around not wanting to prolong life. And so I've had some success where I say, okay, this is plan A. You're going to pursue this as aggressively as you want, but we need to have plan B in place so that when you change your mind and when the time comes, that it's not an emergency, and that it's not an emergency for you and it's not an emergency for your family. And so I think that you can pursue both streams simultaneously. And I'm a big fan of plan Bs. And I have had some success with those patients who are still actively engaged in chemotherapy right up until, you know, the week before they pass away. And if you have a good plan B in place, then it can be implemented quickly and at that moment when it's required. And I'm trying to do more of that as a family doctor. There's a lot of competing time interests, and it's very easy to deal just with the problem that's in front of you. And that's where I found, again, invaluable supports with our home care nurses and our palliative care NP. I find they have more time to have some of these really important conversations with the patient. Resources locally, identifying the patient resources can be a challenge. Quick access to meds, quick access to oxygen therapy can be a real challenge for us and has been recently. And then I think for a good death in the home, specialist support has been valuable at times, being able to reach out to experts in terms of managing specific symptoms. I've found very valuable, and a shout out to Sue Robinson, our former palliative care NP on the island, for being such a content expert for me in the past. I have found providing palliative care to be a very satisfying part of my practice. And it's something I hope to and wish to continue providing for a long time to come. My top tips for someone joining healthcare and to provide palliative care, wishes to provide palliative care, is that the importance of joining a community of care. So recognizing that you are not alone in trying to provide that. I have felt that way ever since I've joined the island, that I'm part of a group of providers, both physicians, home care nurses, and others who are all engaged in the goal of providing good palliative care. So don't try to do it alone. That would be my biggest tip. And be aware of your resources and leverage your resources. I definitely encourage Plan B conversations with patients who, you know, they don't want to talk about palliative care. And I said, look, I know you're not ready to have this conversation. You're not ready to go there, but let's have it ready so that when the time comes, we're not doing it in a pinch. And that having that Plan B increases your chances of being able to have the death in the home that you want. And then I also think it's important for patients to recognize their limitations in their resources. So if a death in the home is not always an option, I think that's important for patients to know that up front, because sometimes what creates the greatest distress is the belief that you can die at home, when in fact, resources will not allow that to happen at any given time. And so I think it's important that our patients are aware of the resources and the limitations to those resources that are available to us. I think that has been my experience around palliative care. And thank you very much for inviting me to join today.
Thank you so much, Simone. Our next presenter is Cindy Thomas. Cindy is a registered nurse. She graduated from the RN program at Sioux College in 1993 and started her career on a cancer unit in Battle Creek, Michigan. She then moved to a renal unit at the Northern Michigan Hospital in Petoskey. She continued her journey back home to Sault Ste. Marie, working in home care in the Sioux, Michigan, and then dividing her time between the Plummer Hospital in Sault Ste. Marie and her visit nurse role. As she says, her heart was in home care, so she finally gave up the hospital job and has been home care ever since. She currently works with the Bayshore Home Health Team in Sault Ste. Marie. So welcome, Cindy.
Hello, can you hear me? No. Sorry. Can you hear me?
Yes, we can hear you.
Hi, I'm an RN working, as Francis said, working in home care in Sault Ste. Marie. I've been doing it for quite some time. I don't know how all the years got ahead of me. I'm very pleased to be a part of this panel today. And I'm glad that I wasn't the first person to speak, because I realize now that everybody's kind of in the same boat here in Northern Ontario, but I'm certainly not as north as the rest of you. Simone, I'm glad to hear you speak. I have family in Manitoulin Island, Chaging and Takama and all those little wee places. So glad to hear that palliative care is taking off in those remote areas. When I hear people like Alexis talk, she sounds like she's holding the bag all by herself, along with Valerie. I have a big support system here with home care. I'm old enough to see how far it's come. I can remember times when I first started out in home care, and we'd have a gentleman that wanted to stay home. He had no family support. He hated his family. The only support system he had was a PSW that would come in and take care of him. And the attitude back then in home care was, if he wants to stay home, that's his problem. Forget it, traumatized me, because the patient wanted to stay home and die at home, but there was nothing in place to help him. He did end up dying alone. I was called when a neighbor in the building heard a big bang, and he had tripped over his tube feeding and his oxygen and died alone. It was traumatizing for me, because I went in and found him there. The ambulance was there, the police were there, the paramedics were there, and all I could think of was he wanted to die at home, which he did, but he did die alone. That was 21 years ago. We have certainly come a long way since then. I think the financial support has made a huge difference. So we don't have any more of those kind of deaths here in Sault Ste. Marie, I hope. In my experience, a lot of it is learned on the job. We've had babies come home to die under a year old with leukemia. We've had young children with leukemia. We've had teenagers, young moms. It happens at every age and stage of life. So the more support that they have, obviously, the better it's going to be. A lot of behind the scenes goes on. And I think in those remote areas, they don't have that luxury. But we have the LINs and the case managers, the palliative case managers really do a lot of behind the scenes work even before the nurse gets into the home. And that's really come a long way. It's really helped when the equipment's on the way and the pharmacy's delivering and all those things fall into place nicely. It makes it so much easier for the family and the nurse that's knocking on the door to start the care. I also wanted to mention that when you talk about introducing palliative care early on in their illness, it really does make a huge difference. The problem that we do see is people that maybe don't have a diagnosis of cancer, and they might be COPDers or those types of chronic illnesses. And you as a home care nurse might be visiting once a week or once every 2 weeks, and you see the decline. And those patients are the ones we worry about falling through the cracks, because the family doctor, might see them every 3 months, and we're in there every 2 weeks, and then we're in there every week, and we see the decline. And so starting those conversations from scratch are kind of tricky. So keeping the family physician informed is really the trick to making sure those patients don't fall between the cracks. Because not every patient has a palliative diagnosis with a stage 4 cancer. And those patients are kind of, I find those the trickiest to maneuver, because the family doesn't believe it's time. So it's trying to get everybody on board to support them for Plan B. Going into the home as a palliative care nurse, so many of you have done it. It's tricky because when you knock on the door, you have no idea what you're walking into. You don't know if the family is supportive. You don't know if there is family. Their family might be caregivers, might be neighbors, they might not have actual blood relatives around. They might be 2 provinces over, those types of things. So early on in the visits, I try to figure out who their support systems are, try to gain a trusting relationship with the patient, and let them know what their options are. We in Sault Ste. Marie have come a long way in terms of 24-hour care. I think the case managers can vouch that we still struggle with evening visits, night visits, PSW visits, those types of things. And when it comes to a good death at home, I have to say that the frontline worker, which is the PSW, plays a very, very important role. And we struggle to get PSWs in. Because the family generally is all on board until it comes time for personal care. You know, they'll do it, but then it can get really, really intimate and really struggling for the family. I mean, you might have a daughter whose father is dying and they're expected to change their brief. Those types of things can get really, really tricky. And that can be the difference between them staying home and not staying home. So we struggle here in Sault Ste. Marie with PSW support, that type of thing. The other thing that's come a long way though for us is, like I said, the 24-hour on-call. Nowadays, we get a symptom relief kit in the home. I think it's somewhere between 40 and 50% on the PPS scale. That symptom relief kit is a godsend for everybody trying to keep the patient at home and not go to emerge for their symptoms. So that's really made a significant difference for palliative care here in Sault Ste. Marie and outlying areas. The symptom relief kit, we can manage things like agitation, delirium, anxiety, those types of things. We also have palliative doctors on call, which is amazing. We get the home care nurses here in Sault Ste. Marie. We get a monthly schedule of doctors that are on call. They can be family physicians that have taken some palliative courses. We have a few of them that specialize in palliative care and work at they all work at the hospital and palliative care, but they're a phone call away for us home care nurses, which is amazing. And now I want to take the opportunity to say that nursing has come so far. When I first started nursing, when I had to call a doctor, it took all my nerve to call a doctor and tell them what the concerns were. Doctors are so much more approachable now. They are not, I don't know how to say it. I think you guys know what I'm trying to say. They're easier to call, they're easier to talk to, they're not as intimidating as it used to be, and it's made all the difference in the world when it comes to palliative care. That everybody is approachable, everybody tries to help each other out, and it's just come, in the last 25 years, it's been a huge difference being able to approach doctors and nurse practitioners with the concerns that we have. So kudos to everybody for that. Wow. So when it comes to managing symptoms in the home, we might do a visit, once a day or twice a day, and we still get a call in the middle of the night. They'll call Bayshore and there'll be a nurse on call. I know I'm making you jealous, Alexis, with all this support that we have here in the Soo. But yes, so at Bayshore and at the other nursing agency, there's a nurse on call. And if it's a palliative patient with a problem, that nurse will go out and make the visit during the night or whenever it need be. And then when we're there, the symptom relief kit is there to help out. And there's also a doctor on call if we need to. So we have really good support system, I feel, here in Sault Ste. Marie. It still doesn't always play out as a good death, but we try to put all those supports in place. With COVID, we've had some more challenges. I know personally in my own family, the patient did not want to go to Arch, but the immediate family members wanted them to go to Arch. If you went to Arch, then only one family member was allowed in the building. So that was a huge challenge. In the end, the family member went and passed away within 2 days. So it played out as best it could. But for some people, a home death, it's the family just can't handle it. And I think it's our job as the professionals to be able to take that guilt off them and say, you know what, you do what you can, and we will do our best to support you if it's time to go to Arch, those types of things. And a lot of it is just plain old common sense. You have to be able to read people. You have to be able to figure out how much they can handle. And you have to be a good listener. And I think that's the biggest part of supporting these people at home. Listen to what the patient wants. Listen to what their problems are, what their concerns are. You might go in there with the goal of getting a DNR certificate signed, and their goal is the swelling in their feet. They can't walk, they can't get to the bathroom, those types of things. So it's about listening to what their needs are and following up with trying to get the right supplies in the home and the right orders that they need to get through, those types of things. The other thing, like Simone said, it's a lot of these patients are still getting active treatment. They still have hope, and it's not our job to crush their hope. So I usually just tell them we're going to take it one day at a time. They might have an appointment the next day, and they're too weak to get to the appointment. So instead of them being overwhelmed, we just say, you know what, we'll deal with it. See how you feel in the morning. Tomorrow's a new day, that type of thing. So they feel supported and not pushed. Keeping the family calm is a big part of a home care nurse because there's a lot of family dynamics that are going on. And our job is just to be supportive. We're not there to fix all their family problems. Our goal is that everybody stays calm and that the patient's symptoms are managed. Some of the problems that we have here still in Sault Ste. Marie, I'm sure they're the same as everyone else's problems. It's education. Home care staff need more education. There needs to be more funding in home care. Those are issues across the board. The other issue that we used to deal with much better was a debriefing after a death in the home. Whether it's a good death or not so good death, everybody, that's the end of it for the people that were supporting them in home care, the PSWs, the nurses, the nurse practitioners. That's the end of it. Sometimes they end up in a merge for one of their problems and they die there. And we're just kind of left as humans feeling a little bit lost. So the debriefing after is an issue. For the family, it's also an issue because we could be in there twice a day for months and months and months, and then the patient dies and the spouse is left with nobody in their house anymore. PSWs aren't coming, the nurses aren't coming, and they're kind of lost. So, we kind of dropped the ball at the bereavement after. And I think there's always talk about trying to get a bereavement visit back in after the person has passed away. The other thing is, I can tell you that the families really appreciate after the patient has passed away, when the nurse practitioner or the doctor or whoever the caregivers involved call them after. A simple phone call after makes all the difference for these patients. I can run into them in a grocery store after and they'll say, do you know, so-and-so called me the next day, and it just made them feel so much better. So we all need to keep that stuff in mind. And I know we're all busy, but these people pass away and they still need support after. I think that's about all I have to say. I appreciate the opportunity, and it's good to hear that other people across the province are all in the same boat as we are here.
Thank you, Cindy. So we're down to our last presenter, who I'll introduce in just a second. Before that, I'll say the chat box is open if you have questions, because I do think we'll have some time for questions or comments or discussion around, I think, a lot of common ground that we've raised in this rich panel so far. So our final presenter is Nathalie Belair. It's very deliberate that we've asked Nathalie to anchor this team. So Nathalie Belair lives in Sault Ste. Marie, and she will bring forward a family member's perspective of death in the home. Earlier this year, at the height of the COVID pandemic, Nathalie moved her parents into her home to care for them at the end of life. In 1989, Nathalie graduated from the Regional School of Nursing Assistants in Thunder Bay and worked as an RPN in long-term care at Hogarth Westmount for approximately 10 years in a casual capacity. Nathalie's current occupation is as Director of Labor Relations, People, and Culture at the Northern Credit Union. So welcome to you, Nathalie.
Thank you. Can you hear me? Good. Just making sure. I do have a presentation that I have put together. I'm very honored for being asked to speak with you and share my experience. It was a very unique experience, and I'm very grateful to each and every one of you and every care provider in the palliative field that supports family and provides this type of opportunity to a family. My experience was very difficult, very emotional. However, I am very grateful and absolutely have no regrets. Francis, at the beginning, you had mentioned regarding the standards and what the goal is of palliative care and a good death. I truly believe that the experience that I've had because of the team and the support that I had in Sault Ste. Marie provided my parents the best death that anybody could ever imagine. I'm not sure how I get the screen.
At the very bottom of your screen, there's some buttons. The third one in from the left is a share content button. So if you hit that, you should be.
Oh, there it is. Sorry. Okay. Sorry here, I'm just going to go to are you able to see my screen?
Yep.
Okay, awesome. And I'm not quite sure. Probably have it wrong, but I don't want to take up too much time neither, because I think it's important that we get through this. Again, this is my perspective, and I really tried to bring it back to the panel discussion that we were having and the questions that were provided to me. So this presentation is very personal, and I thought I'd put a lot of images so that you're able to understand my journey and my family's journey. So again, I want to thank you and let you know how honored I am to be here. So one of the questions was, what does it take? In my opinion, all it takes is love, respect. You absolutely need to have a great sense of humor and a lot of support. One of the things that I found most challenging was accepting the support that was being offered to me when it was being offered. Something as simple as bringing in a meal. You know, it was nice for my neighbors to bring in a meal. It was one less role I had to provide. And so trying to understand and accept the support provided, not only to myself as the primary caregiver of two passing parents, but for my parents as well. My parents were married nearly 60 years. They had a very unique relationship. They fought, but they loved each other so much. And when I talk about a sense of humor, and I'm not sure this will work, but I'm going to try. I've embedded this video. Oh. Don't take my sunshine away. I wanted to share that because it gives you a sense of trying to provide a normal life while going through this journey. So our timeline was quite unique. So back in September, Mom and Dad were still in their apartment, and about mid-September, Dad was assessed for palliative care, in which discussion started to occur about next steps and what palliative meant. And I was grateful to be able to understand what was out there. I started because not only, I also had the power of attorney, and I swear my parents have been preparing me for this day for the last 30 years because of my dad's medical history. We've always been very open about our discussions. We've always made sure that we understood, you know, what was needed, what was there, the financials, what about Mom if something happened to him. So we always had those open discussions. So having him assessed and put into palliative care helped have further discussions in regards to, Dad, what is it you want for your end of life? Then in February, Mom was diagnosed with lung cancer. It was a stage 4 lung cancer, very aggressive. And so we needed to start having further discussions and began Mom's journey into palliative care. Then we have COVID, which was very interesting. And we had Plan A, Plan B, and Plan C, and probably Plan D, E, and F. So they were originally supposed to move into my sister's house, but with COVID, she did not feel comfortable. We had visited our hospice here in Sault Ste. Marie, as that was what was going to occur, because with them moving into my sister's house, death could not occur in her house. I was always prepared to take my parents in, but I didn't want to overstep and take that opportunity away from another sibling as well, and I would always assist. When COVID hit, and my house was not equipped to do this, however, we made it work. My sister got cold feet, didn't think that she could do it. So on a Sunday afternoon, I talked to my sister, I talked to my parents, and within an hour, I had their basic necessities and then moved into my house. My mom was at that time able to do stairs. My father could not do stairs. We put his bed in the dining room, and over time slowly moved them in. We didn't get the stair lift until April, so Dad got some comfort of his own room. My mom had the best room in the house. She was given the master bedroom, so she could have sunlight and have a cheery place. And for the month of April, we tried to do everything we possibly could to laugh, smile, spend family time together. Again, a lot of COVID happening, the province was shut down. Family were afraid to come visit because we had a lot of care providers coming in, the PSWs, the nurses, some appointments. Mom was doing some radiation treatment in order to support the pain. And so it was pretty much my parents, myself, and my son lives with me, he was a godsend. So I had that support as well. And through that time, I was also trying to work full-time from home and do the best that I can. In May began the decline of both parents. And when the decline started, it started to happen fairly quickly, where I needed more support, where I had to make a decision that I couldn't work anymore. And lucky for me, my employer was amazing and supportive. On May 20th, Mom turned 80. On May 22nd, Mom's journey ended. Following the end of Mom's journey, and these are just really high level, and I'll get into some of the more specifics. Following the end of Mom's journey, we used to say that Dad played possum. He would sleep because he didn't want to deal with what was going on. He was so sad, he was heartbroken. It took a week for me to reinforce that Mom had passed. He just couldn't accept it. He rallied to make sure all of the estate stuff was done. He signed his last paper that was required to be signed on behalf of Mom's estate, even though I could do it. He wanted to do it on the Wednesday. And on the Sunday, he passed. And that morning, he knew he was passing. He didn't want to live without Mom. And he didn't want to be a burden. And we had talked a lot in between those 23 days, between Mom's passing and his passing. He was concerned that he was going to live longer and that I would send him away. And I kept reassuring him I would never do that, that we're in this for the long haul and we're in it together. And that whatever his wishes were, they would be granted, because that was the goal that I had set when I moved my parents in. The goal that I had set with the palliative team was that my parents were going to die with the utmost dignity, with no pain, and surrounded by as much love as possible. So, you know, how did I do it and how did you organize yourself was the panel questions. I did it with the support, the amazing support of the palliative care team, recommending and arranging for what we needed when we needed it. And what I mean by that is that team was absolutely amazing. And I may use names, and I'm sorry if I'm not supposed to, but I just might have to. Rita was amazing in stepping back, listening to what the needs were, not forcing, because my dad was difficult. My mom just went with the flow. My mom didn't want to know what her journey was going to be and left it in my hands. My dad wanted to truly understand, but he was stubborn in not wanting to take meds, not wanting to acknowledge that, you know, we can't get up those stairs anymore, even with the stair lift, because my legs can't hold me, acknowledging that I can't walk to the bathroom and that I'm going to need that commode. They gave us time without pushing to provide the support we needed, although it was hard in getting there. And my son would say, you know, we waited way too long for those catheters to come, because 3 days of constant washing, trying to transfer somebody onto the commode, doing things differently, getting the equipment to us that we needed. At one point in time, I was running up and down my stairs with one commode, where the palliative team said, wait, you don't have to do that. We can get you a second commode, which was a godsend. Not knowing what to ask for or what to do. But they were listening to the challenges that I was having or that my family was having, and they intervened at the right time in a gentle way, supporting that I was trying to allow my parents to control their own decision-making and supporting their needs. And then family and friends. I could have not have done it without my son. I could have not have done it without my friends, my extended family. I'm the baby of 4. I'm the youngest sibling. I have a sister who lives in Thunder Bay, and I have 2 other siblings that live here in Sault Ste. Marie. They weren't necessarily accepting of what was going on. They weren't necessarily accepting that my parents were both dying. My brother had just finished his own cancer treatment, and he was having a hard time dealing with all of it. My one sister has anxiety with COVID and everything that was going on. She was petrified to come over to the house. And I needed to be supportive of that. And my sister from Thunder Bay couldn't just get in a car and travel given the COVID situation. So we did everything we could to ensure that she knew what was going. And so there was some challenges there with the family. Again, the palliative care team reached out when asked to the siblings that required that additional assistance, in particular when I just couldn't deal with their angsts. I couldn't be their counselors. I was having a hard enough time being the caregiver as well as a grieving daughter. The pitfalls and the challenges, saying goodbye, being the caregiver, and the daughter in saying goodbye was extremely difficult in finding that balance. I also had multiple roles. Given COVID again, and yes, we had the nurses come in and the PSWs, but I still had to provide meals. I still had to do laundry. I still had to try and be a daughter. I had to give the meds. I did all of their care. They didn't necessarily need to go to the bathroom and or have the accidents just before the PSWs arrived. There was a lot of roles to play. And again, family can be a blessing, but also a curse. One of the biggest challenges that we had as a family was the medications and them not being there 24/7 to see what I seen or to understand the dying process, and that it can be painful and it can be scary, and the additional meds that are required in order to keep comfort for the patients. For my parents in particular, I was accused of over-medicating them. I was, what's the point of coming over if they're so drugged up we can't even have a conversation? I'm grateful to the palliative team of keeping reinforcing the need for it. I understood the need for it, but I almost felt guilty because of some of the family comments that would come back to me. And then balancing when it's time for the next steps, medical intervention to provide loved ones decisions. And again, that goes back to the palliative team that I had, were very supportive and understanding, and they would make recommendations. And it may take a day or two for me to sell it to my parents and or for me to buy into it. Or it may be within 2 hours I'd be phoning back and saying, you know what, I need this now, I can't go on, or this isn't right for my parents. And they were very good at doing the things that were required. I had 2 hospital beds in my living room. I had 2 commodes. I had an amazing journey with the equipment. It would be delivered so quickly, and I'm so grateful. I had regular check-ins and we had Bayshore, and I'm very grateful for Bayshore. For the nurse that I had from Bayshore, she would check in even when she didn't need to. She knew that it was challenging having 2 individuals going through this, and that I was pretty much on my own. She was there whenever I needed her. She provided me her personal phone number so that if I got into a pickle and I didn't use it lightly, I could call her. But just having that number gave me that assurance that I required. One of the things that I struggled with throughout my whole timeline was exhaustion, because it was 24-hour, 7 days a week care that was required. And again, as I said, I also tried to work. I had to finally admit that I couldn't do both. I did have to take a leave of absence. Following the passing of my mother, I took my bereavement leave, and I thought, okay, I could do this. I could go back to work. That was short-lived because Dad's decline was a lot quicker than anticipated or that I thought. I think the team knew it was coming faster than I would acknowledge that it was coming. Dad always rallied back, and he was the man who had 30 lives. And so it kind of, put it into perspective that, yeah, no, this I'm going to lose my dad as well. The PSWs would come in, and as much as I loved having them, it was also more work because they weren't familiar with my home. I was also a control freak, which didn't help any of you and all of them, and wanted to make sure that my parents were getting the best care because my parents were always very difficult in caring for and very demanding and wanted things certain ways. And sometimes the additional support was disruptive, but also wanted it. They may come at a time where I can finally get a nap, but it didn't happen because this, and this was coming with the scheduled appointments. COVID played havoc as well, being short-staffed, needing to find caregivers. Luckily, with my background, I was able to carry a large load, and I don't think that any other family member and or caregiver without having that background could have pulled off what we managed to pull off as a team with the palliative care team. At one point in time, I can tell you that I was so exhausted, I had to have a conversation with Rita because I was so looking, my family wasn't coming around because of COVID and other circumstances. There was just me and my son, as well as the support team. I was so exhausted. I wanted to put them into our hospice, both of them, understanding that there would be only one caregiver. And because I was already the primary caregiver, I would have moved into the hospice with them to be with them, but I could not split them up. And Rita said to me, she said, trust me. Do you remember what the goal is? And I said, yes, and I do trust you, and I trust you all, but I need some sleep. Somehow I need to recharge my batteries. So we developed a plan together. I somehow managed to recharge my batteries, and I was able to fulfill the goal that we had put in place for my parents. And then again, COVID was hard. COVID remains hard. And I can appreciate how difficult it is for all of you to work as well through this difficult time in supporting families with all of the challenges, and kudos to all of you for what you do. How did I measure success? I measured this success by the family. Smiles, by the most intimate moments I was able to have with my parents. It was pretty amazing. I never thought that I would have this type of experience. I never thought that I would do this, but I am so grateful for what I was able to share with my parents and for the gift. And I truly believe it's a gift that my parents trusted me enough to allow me to do this for them. At the bottom, the 3 pictures that are there, that is 2 days prior to my mom passing. My dad so needed closure. My mom somehow rallied and walked over to his bed, and they had the most amazing, intimate conversation of saying goodbye that I am so blessed to have been part of, and I couldn't have done that without all of you. Sorry, I'm getting a little emotional. Top tips and wisdom. Top tips and wisdom, after hearing everything that you've shared and the challenges that you go through as providers, these just seem so kind of irrelevant. Because I do think, given my experience, that it was an amazing experience. I don't have anything bad to say from my experience. I can say that I was one of those individuals that really needed to know and understand next steps. Although I've done long-term care and I've been part of the death and dying process, I needed to understand that PPS scale. I needed to know the whens. I needed to prepare myself mentally. I needed to know when it was time for me to be daughter and when it was time for me to be the caregiver. And then supporting families with their various roles. Because of COVID, and maybe it is the program, it was very difficult to play counselor to my parents because that was something that I was not prepared for. And although that the palliative team did have counseling for me and I had some great resources, my parents weren't prepared to have those discussions directly with the counselors. They relied on me for that. And hearing some of the things that they needed to share for end of life as the daughter and not a counselor was sometimes heart-wrenching. And just, you know, that extra mile for families to be prepared. Sometimes it was really difficult because you didn't want to hear some of the bad things that they were saying. At one point in time, you know, near the end for both of them, they were in quite a bit of pain until we could get their medications up and done while I gave them care. And my mother yelled at me, "You are so rough." It was heart-wrenching, but I also know that I wasn't being rough and acknowledging that, "I'm sorry, Mom, this needs to get done. I know you're uncomfortable. We're going to get you comfortable." But it was still heart-wrenching as the daughter, but not as the nurse. And then support after the passing of caregivers. And I believe Cindy mentioned this in her discussion. And you've seen the dogs throughout my entire presentation. I have 2 dogs, and when I moved my parents in, both dogs took to each one of those parents, and none of those dogs left their sides. Just like the picture in this dog, of the dogs near the beds after their passing, I felt the same way. I was so lost. I had all of this nursing stuff in my home that all came and got picked up. I had people coming in daily to be left on my own, and just that my new norm was so different. And I don't know what anybody could have done. I seriously don't, because I also needed that alone and that quiet time, that balance, to accept and to acknowledge and to deal with what I was dealing with. And as I said, I don't know what the answer is, but I do know the weeks following the passing of both of my parents, I was very, very lost. I did have avenues that I could reach out to. I did use them. I am getting counseling. I'm grateful for that. But it was very strange in my home for the longest time. And again, it wasn't in my loved one's home, it was in my home. So I didn't get to leave that loved one's home and go home. I'm still home, which we made their home. And that's what I put together for you. And I truly hope that this has provided you a little bit of feedback, has shared the good side of my journey with the sad side of my journey. And again, I am so blessed and so grateful for all of the work that you all do. And that I hope that this helps some other family. And if I could ever help another family and or your program, I didn't do this for nothing. I'm just so grateful.
Thank you so much, Natalie, for your story and for sharing. In view of the time, we do not have time for discussion. I just want to say that there are not a lot of questions coming up at this point, but I'd like to say 2 things. One, to just express my gratitude for all our panel presenters for being so honest and frank about who they are and what they do. Also to all the attendees, because I'm hoping that, as Laurie Lee said at the beginning, it takes a village to do this work. She set the tone. We didn't ask her to do that. But I think what that represents is that we have a lot of common ground in our various communities across the North. And perhaps there's ideas that are going to percolate and come up. And what we're going to request is if you have questions, if this is the first step in making this a bigger community, of which we are now all members by virtue of our attendance, we can use our website as a way to funnel in questions, ask for some connections, and we can send those out to the community of people who've attended now. Just to let you know that we will have another session. Our monthly session in October is going to be about grief, trauma, self-care, and resilience with Eugene Dufour, who's a well-known speaker in this area. We may, depending on our feedback, come back to this topic again as another rounds in the future. Our committee is quite flexible. So thanks again for joining us, for sharing. It'll give us a lot to think about, and I appreciate being part of this wonderful community. Have a lovely day to you all.